I'm Dr. Michael Miyazaki, and thank you for joining this program. We're going to talk about the use of bioactive materials to restore teeth. Look at this image right here. I know I colorized it just to make it look a little bit different and make that decay on the right-hand side stand out a little bit more. But have you ever had a patient that presented like this, where they had an area of deep decay, they hadn't been in to see you, or maybe this is the first time they're seeing you, and what do you recommend? So in this patient's case, what we were doing is seeing the patient for the very first time and looked at this after taking a radiograph. You can see we're very close to the pulp. The tooth still tested normal. The patient said the tooth didn't hurt. But from a clinician's point of view, once we touch that tooth, we've kind of taken responsibility for it. So a lot of times what we recommend, and prudently, I believe, is recommend that we do a root canal on the tooth if we deem that we can save it. You can see the mesial decay is fairly deep, subgingival, very close to the bone. So can we get a good margin down there? We don't know yet. Or that alternative is if we get in there and that decay is very extensive and goes maybe below the bone, maybe it'd be better to extract the tooth. Well, that's what I recommended. Let's do a root canal, think about a crown if we can, or maybe just extract the tooth, place an implant later, or removable prosthetic, or maybe do nothing at all. The patient, of course, replies back, well, the tooth doesn't hurt and I don't want to lose my tooth. And then the cost always comes into play where, I can't afford the root canal. And then the crown after that, I don't think I can do that. So what we decided in this case was to tell the patient we could try to restore this tooth because of the area of deep decay. But what we're going to do is we're going to use a bioactive material, not just a filling to fill in a hole, but a bioactive material that will fill that hole so that food doesn't get in there. But this material will help the tooth heal itself and then help prevent recurrent decay. Because obviously this patient's having a hard time keeping this area clean. Even if we put a crown on this tooth, there's always a chance of getting secondary recurrent decay because of that difficulty of keeping this area clean. But we preface that in that if this tooth doesn't heal up, we put the filling in or direct composite restoration in here, and the tooth begins to hurt the patient, then it's a good chance we're going to have to go back and reconsider root canal, crown, or maybe even extract the tooth. Is that kind of a chance the patient wants to take? Well, in this case, the patient did want to take that because of finances and not want to lose the tooth. So we actually placed that large restoration. Now you would think, well, why would I want to take the risk of placing a restoration in a tooth when that decay is so deep? Well, one of the reasons why is I've placed many of these over the last 5 years that I've been using these specific materials that I'm going to talk about today. And let's go back. When I learned to place a filling before, I learned to place an amalgam. An amalgam was basically an inert material that we would place in the hole left after cleaning out the area of decay. So we clean out the area of decay, be left with this large void. I would fill that up with amalgam, which was a filling material, and basically it was just inert. It was not going to help the tooth necessarily heal itself up other than protecting that large wound that was created. And over time it would corrode, and that kind of created the seal between the restorative material and the tooth itself. But the material itself would not help the tooth heal up. So what would we do is we were using different materials like copalite, maybe IRM, and IRM over the deep parts, or let's go back even further, maybe dical over the deepest part of that restoration to stimulate secondary dentin formation, and then maybe some IRM over the top of that, maybe some dical to seal it, and then amalgam over the top. The materials themselves were not truly bioactive. And then a couple decades ago, we saw the proliferation of the term bioactive restorative products, which meant that these products basically help the tooth remineralize itself and strengthen the tooth structure through fluoride release and some other minerals. It could be calcium, fluoride, it could be even phosphates. So back in the 1970s, we saw the glass ionomers, and they were exciting. We had something that we could put into a hole that would release fluoride. The problem is that they weren't aesthetic, they were difficult to handle, and you could not put it in an area of heavy wear. So advanced over all the decades, and now we've got materials that are kind of like a resin mixed with the glass ionomer to release fluoride to hopefully prevent further decay and be more restorative material. So we've kind of advanced over the decades. But are these materials truly bioactive? Well, compared to an amalgam, they are, right? Amalgam being totally inert just would corrode in the patient's mouth. These materials were releasing ions such as fluoride to help the tooth heal and perhaps prevent secondary decay. But today, our definition of bioactive materials is on a totally different level. The bioactive materials that we have today will actually help the tooth heal itself to create more appetite-like tooth structure with the transfer of calcium, phosphates, and fluoride within the restorative interface, and will help the tooth retain its vitality. And that's the reason why when I look at a tooth like the one we started off with during this presentation, I look at it, I know I might even have a small pulp exposure, but let's go ahead and use these new bioactive materials, because the bioactive materials today are there to break the cycle. What's the cycle? Well, we start with a area of decay. We clean that area of decay out. We place a direct restoration. Over time, that direct restoration may develop decay along the margins again, because that was the reason why we got decay in the first place. So we go back in there, we replace that first direct restoration. Well, now our margins get a little bit bigger, the tooth structure gets a little bit thinner, and at some point we may have to do that again and then move into a crown or an onlay to provide cuspal protection, because our original restoration is now wider and wider, taking up a larger part of the tooth structure itself. So we of course want to relieve pain, prevent pain. We want to restore the missing tooth structure and then provide something that looks aesthetic. Most of our patients today have moved away from wanting to have the dark amalgam and gold, and they want something that's more aesthetic. So if we can combine this with materials that are bioactive that help to revitalize the teeth and the periodontal structures, I think that is a very good thing for us to do for our patients. And that is the kind of where bioactive materials are today. So let's go back in the early 1970s. The Vietnam War was going on, and there was a colonel that taught to Dr. Larry Hench. Dr. Larry Hench at the time was working at the University of Florida doing research on different ceramics, but more for space programs, because we were trying to go into space and you had the extreme temperature changes and the radiation. So Dr. Hench was working on ceramics to protect and help us get into space. There was a colonel that had just returned, an Army colonel that had just returned from Vietnam. And of course, that was a horrendous period of our history, and the soldiers were suffering horrific wounds. And they were trying to put these soldiers back together, but the body would reject the different materials that they were using. And so Dr. Hench was asked to take his research and develop something to help put these soldiers back together. So Dr. Hench, with funding from the U.S. Army, went to work and developed what is now called Bioglass 45S5, and that was the solution. What they did is they could take this bioglass material and put it into the body, and it would actually create appetite-like structures to replicate bone. Today they use it, they can print out a little piece of this bioglass implanted in the body, such as the ear, and that bioglass framework will actually turn back into bone. So it was very promising. What has happened is now Dr. John Kenka III, a dentist very well known, a pioneer in adhesive dentistry. One of the first things he taught us is that we could actually place phosphoric acid on dentin and not kill the tooth. When I was in dental school, we were told not to put phosphoric acid on the dentin, which would allow it to get into the dental tubules down to the nerve, and you would kill the tooth. Well, imagine today where you're trying to put the etchant just on the enamel and keep it off the dentin. It's nearly impossible. So today what we know is we can place the phosphoric acid on the enamel and the dentin, and the phosphoric acid is only going to penetrate to a certain depth, and we are not going to kill the nerve. So that's one of the things that Dr. Kenka taught us. Then once we did our etching, we were told when I was in dental school to rinse off that etchant and to dry that tooth, get the enamel bone dry. You want to see that frosty ring of enamel, and of course you were drying the dentin that was right next to it. What Dr. Kenka said was, we're doing it all wrong. What we need to do is we need to leave the dentin moist, not puddled wet, but moist, because then the solvents that are attracted by that moisture would pull our resins down into those dental tubules, and we would get a better, stronger bond and seal those tubules up better, which would then mean less sensitivity and a healthier tooth in the long run. So Dr. Kenka said, hey, phosphoric acid can be placed on the dentin and you're not going to kill the tooth. The adhesive can be applied to moist dentin. It should not be dry, and you'll get actually a better adhesion of our restorative materials to the tooth. Well, combine this with another gentleman, Scott Lamorin. Now, Scott Lamorin was a chemist, and he is now the CEO at Vista Apex. The two of them took the idea of the BioGlass 45S5, the knowledge that Dr. Kenka had on working with the tooth and creating a good bond, and the chemistry that Scott Lamorin was able to develop, and bring the two together. So now we would have an adhesive with the BioGlass 45S5, and we would have restorative materials with the BioGlass 45 all in one. Now remember, what was happening at the time was we did have some bioactive materials, but we at first some of these bioactive materials said, hey, just place it on the tooth. It's kind of, it'll bond to the tooth, and you'll have all this bioactivity. It's going to be the greatest thing. Well, what we found out was the bond strengths were really, really inadequate. So you would use this bioactive material, you would do your direct restoration, and over time that restoration would fail because it wasn't truly bonded to the tooth. So then the manufacturer of that material came back and said, okay, I tell you what, go ahead and place your adhesive. So now we had an adhesion layer, and then place this bioactive material, which was fine. It was better than what we were doing before. But now we're placing this bioactive restorative material into the tooth, but the bioactivity of that material could not benefit all the deeper parts of the tooth where the tubules were, because we had sealed them up with our conventional adhesive. So we had a conventional adhesive that would seal up all the tubules. We'd place this bioactive material on the outside. It would do a better job perhaps at preventing recurrent decay, because now it was bonded. It wasn't loose. It wasn't wiggling around in our preparation, but it wasn't going to help the tooth heal up. What this new suite of materials that contain the 45S5 allow us to do is actually place the BioGlass bioactive material into the tubules, and that's where it can assist the tooth in healing. We're going to get a better bond, we're going to get a better seal, and then we place this reservoir of the bioactive glass, the 45S5, over that adhesive layer. We cure it all together, and now we get the benefits of having a bioactive material right into those tubules and a restorative product as a reservoir of this 45S5 bioglass on the outside. It's really bringing together everything, and if you watch some of our other YouTube videos, now you understand we're using this as our bioactive endodontic sealer. Why? Let me explain that. What these materials do is they help the tooth create appetite-like tooth structures, but let's step outside. Let's talk about first what it does to the pH. What the BioGlass 45S5 does, it helps to create an alkaline environment. And this alkaline environment helps to prevent the proliferation of bacteria. Bacteria doesn't like an alkaline environment. It wants a more acidic environment. And that's why areas where we get decay, that's the acidic environment, where we have the acidic environment there. The bacteria proliferate, cause periodontal disease, and cause tooth disease, tooth destruction. What the BioGlass 45S5 does is it neutralizes the acidity. And I remember that point. It neutralizes the acidity. So here's an example. Here's a beaker. And of course it's two beakers, but kind of the video has been photoshopped to show it as one. When the beaker is pink, the solution that has a pH indicator in it, that means that solution is basic. So that's what we'd like around the tooth. We'd like that in the oral environment. When it turns yellow, that solution is acidic. But that acidic environment means the bacteria can proliferate more and we can get decay. So what we're going to do is we're going to add acid to this beaker. And the beaker right now is pink, so it's basic in pH. As we add the acid, the solution is going to turn yellow because it's going to go from basic to acidic. Well, let's see what happens when this acid is added. So here we go. We're going to stir this up. or adding acid into the beaker turns yellow. The right hand side stays yellow. The left hand side, you can see, is the acidity is being neutralized and is turning basic again. So what they'll do again is they'll introduce an acid again, and as they introduce the acid again, the yellow side stays yellow, and the right side stays yellow. The left side turns pink. It's neutralizing the acidity. So how does it do that? Well, the bioactive glass is buffering out the acidity. On the right hand side, we just have normal fillers that you'd find in a conventional composite restorative material. On the left hand side, you see Regen, which is a restorative composite material that has the Bioglass 45S5 in it. So the filler material, partially being Bioglass 45S5, is neutralizing the acidity. Well, now we talked about this ion exchange. So if we place a Bioglass material that's going to attract calcium and phosphate to it, what's it going to do over time? Is it going to attract those ions? And those ions are the ions that we want to create the apatite-like material. But if we have any tooth destruction, it would be great to attract back the calcium phosphates to help the tooth heal up. So in this experiment, what's happened is there's this beaker, and in this beaker, there's artificial saliva. So it has a similar concentration of your calcium phosphates and other minerals like saliva. There are little composite discs, about quarter-sized discs, that you can see are suspended in this little plastic beaker. One of these discs is just regular composite. The other disc is the Bioactive composite disc that has the Bioglass 45S5 in it. Now, in this beaker of saliva, what would you expect to happen? Well, the composite really shouldn't attract much of the calcium and phosphate. It's basically an inert type of material that's just aesthetic and fills up defects in a tooth. The Bioglass containing composite disc should attract calcium and phosphate to it. So it should have a different looking surface. So what happened was these composite discs were suspended in this beaker containing artificial saliva, which was stirred for 2 weeks. And at the end of the 2 weeks, you can see on the left-hand side, that is a quarter-size composite disc of conventional composite, and it remained smooth because there was nothing that would attract calcium and phosphate to that disc, right? So that's your no bioactive glass containing disc. On the right hand side, as we unveil this, look what happens. It has this orange peel look to it because the calcium phosphate was attracted to that disc because that disc has bioactive glass in it. So we have that bioactive glass attraction. And imagine if that's your restorative material, what would happen? Well, if I use this bioactive glass in my restorative material, one, it's going to neutralize the acidity, so the bacteria isn't going to proliferate or want to even live around our restorative material, right? So if I had a subgingival direct composite restoration, the tissue would be healthier there. There'd be less bacteria down there. The bacteria would not cling to our margins because it doesn't want to be there. But if the patient was perhaps eating or drinking very acidic foods or liquids, and we did get some demineralization of the tooth in that area, well, the bioactive glass would attract calcium phosphate to re-mineralize that area of the tooth to prevent degradation of the tooth. So you think, well, can this really happen? There was an independent study done by Dr. Nate Lawson at the University of Alabama. And what Dr. Lawson did was he designed this study to measure and compare the zone of protection around the bioactive adhesive and the bioactive resin composite following an in vitro artificial caries model in human extracted teeth. So what did he do? He took extracted teeth and he cut little box preps in the DJ area of human molars. And he had 10 teeth like that. Well, he then filled those box preparations differently. Some he went ahead and did the etching and placed a bioactive adhesive, and then he placed a bioactive restorative material. Some he didn't use bioactive adhesive, he used a conventional adhesive with the bioactive composite material. Others use a conventional adhesive with the conventional composite restorative material. Took all these teeth, place him in a demineralization solution for 4 hours, and then in a remineralization solution for 20 hours. And he did this for 30 days. So you would think it's kind of like us eating. When we're eating, we have acid in our teeth for a few hours of the day, and then during the rest of the day, we just have our saliva around the teeth, kind of hopefully remineralizing and diluting the acid. So these tooth specimens were embedded and then sectioned after that 30 days. And what Dr. Lawson wanted to do is he wanted to see what is happening at that restorative material tooth interface. And the results were interesting. So the green bars are good. That's where there was an inhibition of the demineralization at the margin of the restorative material in the tooth. The red bars are where the bad stuff happened. That is where the tooth actually was going through degradation, and we have what we call marginal leakage in those areas. So where did we have the highest green bars? Well, if you look at the bottom, that's where we had the regen, the bioactive adhesive with the bioactive composite combined. Why is that? Well, because the dental tubules and the margin of our preps were coated with a bioactive adhesive. Then over that we had the bioactive composite that contained BioGlass 45S5. So that's where we had the best result. The next highest green bar as we move to the right is where we use a conventional adhesive with the regen flowable composite. So what was done here is that a conventional adhesive was placed over the dental tubules, but then that reservoir of BioGlass in the regen flowable composite was placed over the top, and that then created an area of inhibition so that the acidity of our agents did not break down the tooth. If you go way over to the far right hand side, there was a green bar, and that was Sention. That was kind of a control that was thrown in there. It's a amalgam alternative, not easy to use. You have to mix the liquid powder together, and I don't even think it's available in the United States, but it's just an example of restorative material that has that ion exchange, and it too did very well, but it isn't very practical, and I don't even think it's available to us right now. So I kind of put that to the side. But where you see the red bars is that's where we had the regen adhesive. So the first red bar from the left-hand side is where we have regen adhesive used with just a reference composite. And why would you not expect that to do well? Well, you know, the regen adhesive would be very thin, maybe 8 to 9 microns in film thickness. So there's not going to be a lot of BioGlass in that really thin layer. And now you put a regular composite over the top. So it's not going to have a lot of bioactivity to it. If you look at the next red bar over, that's just using a regular adhesive with a regular composite. Because again, the regular adhesive and the regular composite aren't going to have any bioactivity, and you can see that over time. And Dr. Lawson's SEM showed it that we actually had a loss of tooth structure where the restorative material and the tooth came together. So, you know, it just shows that if you've got a bioactive adhesive with a large reservoir, that bioactive glass 45S5, that does a great job of protecting the tooth. So we have that acidic oral environment, and the regen with the BioGlass 45 attracting the calcium phosphate and the fluoride with the fluoride release helps to neutralize that acidity and create an environment where we're less likely to get recurrent decay and have the tooth actually help to heal itself and create an appetite-like structure. So here's a clinical example of a patient that came into our office. These two bicuspids were a concern of the patient. You can see on the patient's right-hand side, left-hand side as we look at the maxillocclusal arch, there's 3 crowns placed there. So the patient went to a dentist. The dentist probably had decay that looked like this. I didn't have access to the radiographs. And the patient had 3 crowns placed, and I believe a root canal done. And the patient wanted a second opinion because on the left-hand side, after going through the root canal and the 3 crowns, wasn't looking forward to going through that again. So as with that first example, I told the patient, I said, well, I think maybe your dentist, the one that did the work on the other side, treated you properly. Because if the decay looked like this, it's very deep. It's very close to the nerve. So this tooth probably should have a root canal and a crown placed on it. The tooth behind that, the decay again looks very deep. So after cleaning that out, there's a good chance that we would not have a sufficient amount of tooth structure. So there's a good chance that even if we didn't have to do a root canal there, that a crown would be recommended in that tooth. And the molar in this case, well, on this radiograph, we don't have the contact broken, but you can see intraorally there's some dark stain up there. So maybe a direct composite restoration would be okay. So that was what we explained to the patient. And you can see on the lower arch, she's missing some teeth. So we mentioned, well, maybe some orthodontics to open up those spaces, upright the molars, and then place implants. So I bring that up because, you know, what we try to do is tell the patient what a complete treatment plan would be. This was just a consultation, but I try to point out different things that the patient should be aware of. So the patient said, well, let's try, because I forgot to mention, you know, the other option I told the patient is we could try remove the decay and use our bioactive materials to restore these teeth. If you really don't want to do a root canal, you really don't want to do a crown, but I would preface this by saying there's a good chance you might need a root canal and a crown later down the road. So we got in there, we numbed the patient up. You can see we started to remove the decay here. We haven't removed it all, but now we've removed a lot of the soft leathery dentin, and we're getting down to more firm dentin, but you can see it's still very dark. So as I get down here, I'm telling the patient, wow, you know, we don't have a lot of tooth structure left here. We're very close to the nerve on that first bicuspid. I just want to let you know, we don't have an exposure. So I got down there, and now we're starting to fill these preparations up with our direct composite restoration. You can see that they're really deep, but what do? I get down in here, I control the bleeding so we don't have contamination. I get in there and we etch the tooth, and we'll talk about different ways to etch this tooth so we don't cause bleeding down the gingival margin. I soak this area with my bioactive adhesive. I want to get that into those tubules because I know I'm really close to the nerve. And then I'm going to place my flowable composite, my regen flowable composite, down at that gingival margin to get that reservoir of Bioglass 4.5 down there. We restored these with just direct composite restorations. You can see that they're very large. The composites don't look bad, and the patient never really had any discomfort, and we did these a couple years ago. So what I want to let you know is that now you know the rest of the story. This broadcaster that a lot of you may know, Paul Harvey, and he would tell these great stories, and at the end of the story he'd say, and now you know the rest of the story. Because where I started off first showing you that larger decay in that molar, you would think, why is he even trying to restore that? Why not just extract or do the root canal? Aren't you doomed to have a patient that's going to complain of a toothache if you try to get away doing that with the direct restoration? And if you've looked at our other YouTube videos where I was doing root canals, you might have seen that, you know, an overfill here. Well, isn't that going to cause a patient discomfort? Remember, with these materials, this bioactive sealer based on the 4.5S5 technology, we've got a truly bioactive material that goes down there. It creates an alkaline environment. So if I have a puff of sealer that goes out there, it's going to be basic, not acidic. So it's not going to create that post-op tenderness that a lot of patients that I've worked on in the past have experienced when we had a more acidic sealer. This is going to encourage healing in that area. And what are we going to do over the top of that gutta percha once I trim it off? Is we're going to place a regen bulk fill core material. So again, it's going to help us create a more bioactive, physiologic seal up at the top, so there's less chance of any kind of bacterial invasion down into our completed root canal. Why is that important with the bulk fill? Because when I place a large bulk of material, we know we get that volumetric shrinkage. And some of the research shows that if I get a very good bond to the tooth and I have my core material shrink up, that you can actually put stress on that periclavicular tooth structure in that area. But the bulk fill material, because it's allowed to set and cure, and we're not activating that with a light. Well, with the light too, we have to worry about the penetration of our light. But with this shrinkage, we'll have less shrinkage stress. So this regen material is now in our universal adhesive, our self-etch adhesives, our flowable composite, our bulk fill materials, our Pitt and Fisher cement materials, and our Bioactive endo sealer. So this is great technology that we really want you to understand. We will talk about more of the steps of how to use this material in future webinars. And just some of the other things that I'm excited to share. We've talked about tissue management. We're going to talk about some of the etching alternatives, and I mentioned it earlier during this recording. We're going to talk about the desensitizers more. We're going to talk about curing lights even more than I have talked about them in past webinars. And we'll talk about how we can use our curing lights to get the tight contacts, because we'll talk about how to get tight contacts, but every once in a while I talk to clinicians that are still having a problem getting tight contacts, and our curing light may have an answer for you. So again, thank you very much for watching. Please hit subscribe on the YouTube, because we don't want you to miss any of this information. Sorry to make this one so long. I try to keep them under a half an hour, just so you can watch them, take the information, and implement the use of it right away. But again, we've got a great community building. It's building really fast, so please share this information with your colleagues and give me feedback too. We want to know how we can help you improve your clinical results with less frustration. And I think what you're seeing is a lot of the materials that I'm describing and the techniques you can use in your everyday dentistry. So thank you very much for watching another episode. Take care. Thank you very much.